if the cyst ruptures, the patient can die.
It's a pretty chilling way to start a conversation, isn't it?
It really is. I mean, it terrified me immediately. But
Yeah.
that is the literal opening line of the material we are covering today for you all.
Right, because we aren't just talking about, a mild infection here.
No.
Or just some generic lump.
We are talking about what I can really only describe as a biological ticking time bomb sitting inside the human body.
And specifically, usually sitting right inside the liver.
Right. So today we are doing a deep dive into the hydatid cyst of the liver.
Yes.
Now, before you tune out thinking this is just going to be some dry medical textbook recitation, you really need to understand the source material we're working with today.
It's intense.
Very. This isn't a general biology book. This is a high-yield surgical guide.
Which is a very specific, very intense genre of literature.
Exactly. I mean, it's essentially the cheat sheet used by surgeons.
Right, the ones preparing for their absolute toughest exams.
The Viva.
The Earl boards, exactly.
These are the notes designed for that exact moment when a senior surgeon is just grilling a junior surgeon. Staring them down and asking, what do you do right now to save this life?
And puts a very specific lens on all the information.
It really strips away the fluff, doesn't it?
It completely strips it away. It's not about, the history of the discovery back in the 1800s
Right.
or the molecular weight of the proteins involved. It's strictly about survival.
Do this, don't do that, or you kill the patient.
Exactly. And that intensity, it's entirely warranted here.
Because when you look at the biology of this thing, it really is a fortress.
It is.
It's this siege scenario occurring on a microscopic level.
That eventually becomes very, very macroscopic.
Yeah. And the recurring theme you're going to hear today, and I want you to keep this in the back of your mind as we go through this, is the absolute cost of a mistake.
Right. Because in this specific pathology, a single error.
Specifically, spillage.
Yes.
Yeah.
Much. A single error leads to pure catastrophe.
So our mission today for this deep dive is to unpack this fortress.
We're going to look at the invader itself.
The architecture of this cyst, which is surprisingly complex.
It is. And then the high-stakes bomb defusal techniques that surgeons have to use to actually get it out.
It really is biological warfare.
It truly is.
So let's meet the bad guy, the culprit.
Right.
What are we dealing with here?
We are dealing with an organism called Echinococcus granulosus.
Echinococcus granulosus.
Quite a mouthful.
It sounds almost prehistoric, like a dinosaur.
It does, but it's actually a tapeworm.
A tiny one.
A very tiny one. But to understand why it ends up in a human liver, we kind of have to look at its life cycle.
And this is where things get a little unglamorous.
Unglamorous is a very polite way of putting it.
Well, the source material outlines this triangle of hosts, right?
So in the parasite's perfect world, humans actually don't even exist.
We aren't part of the plan.
Not at all. The cycle is designed for just two players. The definitive host and the intermediate host.
Got it.
The definitive host is the dog.
Man's best friend.
Unfortunately, yes.
Yeah.
The adult tapeworm, it lives its life in the dog's intestine.
And it's happy there.
Perfectly happy.
Yeah.
It produces eggs, which then pass out into the dog's feces.
Lovely. Just lovely. And
Then you have the intermediate host,
which is?
typically livestock, so sheep or cattle.
Okay, so they're just out grazing.
They graze on grass that has been contaminated by the dog feces.
Right.
They ingest the eggs.
And then what happens inside the sheep?
The eggs hatch. They form cysts in the sheep's organs. And then eventually the sheep dies or is slaughtered.
And the dog eats it.
Exactly.
Okay.
The dog eats the infected sheep meat or the offal, and the cycle completely closes.
So nature intends for this parasite to basically just cycle between dogs and sheep forever?
It's a closed loop.
Dog eats sheep eats grass, dog poops on grass, the circle of life.
Precisely. Until, a human steps in.
Right, because the source explicitly calls humans the accidental intermediate host.
And that's the absolute key phrase here. We are an accident.
The parasite doesn't actually want to be in us.
No. From the worm's perspective, a human is a dead end.
Because we don't typically get eaten by dogs.
Exactly. So if the parasite gets into us, it can't complete its life cycle. It just gets permanently stuck.
And how do we even get into this mess in the first place?
Well, usually it boils down to hygiene.
Okay.
A human ingests the eggs through food or water that's been contaminated with dog feces.
Or even just.
Or even just by letting an infected dog lick their face.
Wow. Which is a stark reminder for all the dog owners out there.
Wash your hands. Always. But once those eggs are ingested, they hatch right in the human intestine.
And then they start to move.
Yeah, the larvae penetrate the gut wall and they literally enter the bloodstream.
Which brings us to a really fascinating physiological concept mentioned in the guide.
The first filter.
Yes, the first filter. I loved this part of the notes because it finally explains the why.
Right.
Why is it always the liver? It's not just random bad luck, is it?
It's not random at all. It's basically plumbing.
Plumbing.
Yeah, think about the anatomy of the human body.
Okay.
When you eat something, your intestines absorb all the nutrients.
Right.
But that blood, the blood coming directly from the gut, it doesn't go straight back to the heart.
Because it's dirty blood.
Exactly. It's full of food, sure, but potentially toxins and bacteria, too.
It needs a checkpoint.
It needs a major checkpoint. And the portal vein is the highway that takes all that blood from the intestines directly to the liver.
So the liver is the processing plan.
It filters everything.
The liver is essentially the bouncer at the club.
It is the bouncer.
Right.
And it has these microscopic channels called sinusoids.
Okay.
So when the Echinococcus larvae come floating down that portal vein, they hit the liver's meshwork.
And because they are relatively large.
Yeah, about the size of a red blood cell or a bit bigger.
They physically get stuck.
They get completely stuck in the mesh.
So the liver is actually doing its job perfectly here. It catches the invader.
It really does. It filters the blood just like it's supposed to.
But by catching the invader, it becomes the victim.
Exactly. The parasite gets stuck in the liver tissue and basically decides, well, I can't go any further. I might as well build a house right here.
And that is exactly how the cyst begins.
That explains why about 75% of these cysts are found in the liver.
It's simply the first net they hit.
Yes.
Now, the notes do mention a second filter as well. Just briefly, what happens if the bouncer misses?
Well, if the larva is somehow small enough to slip through the liver, or if it manages to bypass that filter, the blood flows up to the heart.
Okay.
And the heart pumps it. Where?
To the lungs, to get oxygen.
Exactly. So the lungs act as the second filter.
Which is why the lungs are the second most common site for these cysts.
Right. And if it somehow gets past the lungs, then it's just a free-for-all.
It can go anywhere.
Brain, bones, kidneys. But usually the liver takes the bullet.
Okay, so the larva is stuck in the liver. It starts to grow.
Yes.
And this is where we get into the actual architecture of the cyst itself.
This is crucial.
The source material uses a really specific mnemonic for this, which I found so helpful.
PEG. PEG.
PEG.
This is classic medical education right here.
Yeah, it really is.
PEG describes the 3 distinct layers of the cyst wall.
And if you're a surgeon, you need to know this.
You have to be able to visualize these layers in your sleep because they dictate exactly how you operate.
Okay, let's break them down for everyone. P is for paracyst.
Right. The paracyst is the outermost layer.
Okay.
But here is the twist, and this is a favorite question for examiners to catch students on.
Oh, I saw this.
The paracyst is not made by the parasite.
Wait, really? Let's pause on that.
Really? The paracyst is made by the host. By you.
So my body builds the outer wall of the invader's fortress.
Yes. It's a defense mechanism.
That's wild.
Your body realizes there is a foreign object growing inside the liver.
And it can't destroy it.
No. The parasite is way too resilient, so the body just tries to wall it off.
It creates a dense, fibrous reaction around it.
Exactly. It's like pouring concrete around a bomb to contain the blast.
That is just fascinating. It's literally a containment zone made of human tissue.
Correct. And that is absolutely crucial for the surgeon to know.
Why?
Because since it is human tissue, the paracyst has a blood supply.
Oh.
It bleeds. If you cut into the paracyst, you are cutting into the patient, not the worm.
Okay, so that's the P. Moving inward, we pass the human-made wall and we hit the E, the ectocyst.
Now we are looking at the parasite's own construction.
Okay.
The ectocyst is a laminated membrane.
And the source describes it visually as being white, like boiled egg white.
That's a very vivid image, isn't it?
It really is. It sticks in your mind.
And it's the most recognizable layer when you look at it with the naked eye.
What doctors call looking at it grossly.
Right. If you cut it open, that white rubbery layer is the ectocyst.
And it's a cellular, right?
Yes. It's basically an elastic protective shield.
Okay, and then deep inside, past the shield, we have the G, the endocyst.
The endocyst or the germinal layer.
The germinal layer?
This is the business end of the creature. This is the living, beating heart of the parasite.
The factory.
It is the factory. It's a very thin layer, actually.
Oh.
Only 1 cell thick, lining the very inside of the ectocyst.
But this is where all the production happens.
Yes. It produces the larval stage tapeworms, which are called scolices.
Okay.
And it produces daughter cysts.
Oh, I saw that warning in the notes, that common trap regarding daughter cysts.
Right, because students often think daughter cysts bud off from the outside, like a cactus.
But they don't.
No, they don't.
Yeah.
They are produced internally by the endocyst.
So you have a mother cyst.
And inside that cyst, floating in the fluid, are smaller daughter cysts.
It's like Russian nesting dolls from hell.
That is a horrifying but very effective visual.
Okay, so we've got this fortress.
Yep.
Human wall on the outside, which is the paracyst, rubbery shield in the middle, the ectocyst, and the alien factory on the inside, the endocyst.
You've got it.
Now let's talk about what's actually sloshing around inside this thing.
The fluid.
Yeah, because the notes mention hydatid sand.
Yes. And, sand sounds harmless, maybe even pleasant, like a vacation.
Right.
Hydatid sand is anything but.
What is it exactly?
Well, if you were to peer into the fluid of the cyst, you'd see the sediment just settling at the bottom.
Okay.
That sediment is a mixture of scolices, which are the baby tapeworms, hooklets, and brood capsules.
Brood capsules, what are those?
Think of them as little packets of worms.
Oh, wow.
The endocyst buds off these tiny sacs, and inside each sac, multiple worms develop.
And when that sac bursts,
it releases all those worms into the fluid.
So that gritty sediment at the bottom is literally thousands of potential worms just waiting to be released.
Exactly.
And the fluid itself, what does it look like?
This is a really key diagnostic feature. The fluid is crystal clear and completely colorless.
See, old surgeons called it rock water, right?
Yes, it looks like pure spring water.
So if a doctor puts a needle in a lump and pulls out pus, it's not this.
Exactly. If it's yellow or bloody or green, it's likely an abscess or something else entirely.
Right.
But if you get crystal clear water, your heart should skip a beat.
Because that is hydatid fluid.
That is hydatid fluid.
And the source mentions it actually has a specific taste.
Yeah.
Not that anyone should be tasting it.
Ideally not. Please, don't taste the medical waste.
Seriously.
But chemically, it is salty. It is distinctively saline.
Salt and sand? I mean, it sounds like a beach trip, but it's a parasite.
A very, very dangerous beach trip.
There's another visual term used in the imaging section of the guide, the water lily sign.
Right. Medicine has this really strange habit of using poetic names for terrible pathologies.
Truly. So what is a water lily sign?
So imagine we are looking at an ultrasound or a CT scan. The fluid in a healthy cyst is black on an ultrasound.
Makes sense.
But sometimes the inner membranes, the ectocyst and endocyst, they detach from the outer paracyst.
Okay.
They collapse inward and they just float in that clear fluid.
Like a deflated balloon inside a box.
Exactly like that. And on the screen, those crumpled white membranes floating in the black fluid.
They look like a water lily.
They look like a water lily floating on a pond.
It sounds beautiful.
It's visually striking, sure.
But diagnostically?
Diagnostically, it means the cyst has lost its integrity. The parasite might be dying or the pressure has dropped. It is a hallmark sign.
So if you see the water lily, you know exactly what you're dealing with.
Without a doubt.
Okay, so we've established what it is and what it looks like.
Yes.
Now we enter the diagnostic minefield.
The minefield.
This section of the source material was incredibly stressed. There seems to be one rule above all others when it comes to figuring out if a patient actually has this.
Yes. The do not touch rule.
Walk us through this, because a doctor sees a cyst on an ultrasound.
Right.
Why can't they just stick a needle in it to see what's inside?
It seems logical.
It seems like the logical first step for most lumps. Fine needle aspiration, right?
Right. And for almost any other cyst in the body, a breast cyst, a thyroid cyst, that is exactly the logical step.
You stick a needle in, get a sample, send it to the lab.
But for a suspected hydatid cyst, blind aspiration is an absolute contraindication.
Meaning never, ever do this.
Never. It is quite literally malpractice.
Why? What happens if you poke the bear?
Two things, and they are both catastrophic. First, anaphylaxis.
An allergic reaction.
A massive system-wide crash.
Because of the fluid.
Right. The fluid inside that cyst is just packed with parasitic antigens.
And your body's immune system has been walled off from them by those cyst layers.
Exactly. So if you puncture that wall and leak even a tiny amount of that fluid into the bloodstream,
the immune system goes into shock.
Into absolute shock.
Like a nut allergy, but 1,000 times worse.
Yes. Sudden hypotension, airway collapse, cardiac arrest. The patient can literally die right there on the table from a simple needle prick.
That is terrifying.
It is.
Yeah.
And the second risk is peritoneal dissemination.
Which sounds like spreading the problem everywhere.
It's exactly that. Remember the hydatid sand we talked about?
The baby tapeworm.
Right. If you leak that fluid into the abdominal cavity, the peritoneum,
You are planting seeds.
you're planting seeds. Each one of those microscopic scolices can grow into a brand new cyst.
So you try to drain one cyst.
And 5 years later, the patient comes back with 100 cysts.
What?
Exactly. You turn one solvable problem into a completely incurable disease. Secondary hydatidosis.
So the rule is absolute.
You must know what it is before you stick anything into it.
You diagnose with your eyes, meaning imaging.
And your blood tests, the serology. Never with a needle.
Speaking of blood tests, the source mentions the Casoni test.
Ah, the Casoni test. This is a bit of a history lesson.
Yeah, it says it's historically important but obsolete, so why even include it in the guide?
Because the people writing the exams are often of a generation where this was the gold standard.
Ah, wait.
It's still asked about in the Viva. It was an old skin test.
Like an allergy test.
Kind of. Injecting a bit of fluid into the arm to see if a wheal developed.
But it wasn't great.
It was not very specific. We just don't use it anymore because we have much better tools now.
Like ELISA.
Right, ELISA, which looks for specific antibodies in the blood.
So for you listening or studying, if you hear Casoni, think history of hydatid.
But don't expect your doctor to order one today.
Correct. Stick to ELISA and ultrasound.
Yep.
Got it. So rely on the ultrasound, the WHO classification from CE1 to CE5, and the blood work.
And do not poke it.
Do not poke it. Which brings us to the main event.
Treatment.
Treatment. The source material says everything revolves around one core philosophy. We've touched on it, but let's make it the big headline.
The headline is, avoid spillage.
It seems simple enough. Don't spill the poison.
It sounds simple, but physically, it is incredibly difficult.
Why is it so hard?
You have to remember, the liver moves when you breathe.
Oh, right.
It bleeds when you touch it.
Yeah.
You are trying to remove a highly pressurized balloon filled with poison from inside a solid organ that is basically like a wet sponge.
That sounds like a nightmare.
Every single technique we discuss, whether it's drugs, needles, or knives, is explicitly designed to mitigate the risk of spilling that fluid.
Okay, let's start with the drugs then. Albendazole.
Right. You don't just book surgery for tomorrow morning.
Yeah.
You have to prep the battlefield.
Albendazole is the drug of choice.
Yes.
And the timeline really matters here, right? The source specifies at least 4 weeks.
This is crucial. You give albendazole for a month before any procedure.
Why 4 weeks, though? Why not just a few days of heavy doses?
Because the drug actually has to get into the fortress.
Oh.
Remember, the parasite layers have absolutely no blood supply.
So the drug has to diffuse.
It has to diffuse from the patient's blood all the way through the fibrous paracyst, through the laminated ectocyst, to finally reach the germinal layer.
That takes time.
It takes a lot of time.
It's a slow siege. You're starving them out.
Essentially, yes. Albendazole inhibits glucose uptake.
So it starves the parasite of energy.
Exactly. You want to weaken the cyst, maybe even kill the skulls, before you ever open the patient.
It's an insurance policy.
Right. Because if you do spill some fluid during surgery, hopefully the albendazole has already sterilized it.
So it won't grow new cysts.
Exactly.
Okay, so now for the actual removal, there's a procedure with a very catchy acronym, PA. PAIR.
This is the minimally invasive option. It's not open surgery.
Okay.
It's done with a needle, usually under ultrasound guidance.
Wait, hold on. You just spent like 5 minutes telling us never stick a needle in it?
Uh-huh. I said never stick a needle in it blindly for diagnosis.
Okay.
Once you know what it is, and you have prepped the patient with albendazole for a month, and you have anaphylaxis kits ready to go,
then you can use a needle.
then you can use a needle for treatment.
But it has to be done in a very specific sequence.
Hence, PIR.
Okay, walk us through the letters.
P is for puncture. You enter the cyst with a needle.
Okay.
A is for aspiration. You suck out a significant amount of the cyst fluid right away.
To lower the pressure.
Exactly. This lowers the pressure inside the cyst, making it way less likely to burst. Is for injection. And this is the really intense part. You inject a scolicidal agent.
Scolicidal, meaning killer of scolices.
Yes. The source lists the main weapons here. 20% hypertonic saline or absolute alcohol.
Let's pause on that saline for a second. Normal saline, like the stuff in a standard IV bag, is 0.9% salt.
Great.
20% seems extreme.
It's incredibly salty. It's actually toxic.
Wow.
If you injected that into a regular vein, you'd cause serious damage.
But inside the cyst?
Inside the cyst, it acts as an osmotic bomb.
Osmotic bomb.
So it draws water out of the parasite cells so violently that they essentially just implode.
And absolute alcohol.
Yeah, that's 95 to 99% ethanol.
Pure alcohol.
It fixes proteins on contact. It kills absolutely everything it touches.
So you inject this poison, you let it sit for a bit.
And then
Reaspiration.
Right. You suck the poison and the dead parasite debris back out. You do not leave it in there.
Puncture, aspirate, inject, reaspirate. Pay.
It's a very elegant procedure. But, and there's always a but in medicine.
It's not for everyone?
No.
Who is it for?
It's for uncomplicated cysts. Active cysts with clear fluid, classified as CE1 and CE3.
And who is it not for?
You absolutely cannot use para for superficial cysts.
Ones sitting right on the surface of the liver.
Because if you puncture those, they might just burst right into the belly.
And crucially, you cannot use it for cysts that communicate with the biliary tree.
The bile ducts.
Why is that a deal breaker?
Well, imagine you inject that 99% alcohol or that super concentrated salt.
Right.
And the cyst actually has a hole connecting it directly to the bile ducts. Where did that alcohol go?
Into the bile ducts.
And it burns them. Completely strips the lining of the biliary tree.
That sounds really bad.
It causes sclerosing cholangitis, which is severe scarring of the ducts.
Oh.
The liver can't drain bile anymore. The patient turns yellow and might literally need a liver transplant. It is a massive disaster.
So you have to be absolutely sure the fortress is sealed before you gas it.
Precisely. They usually test for bile in the aspirated fluid before they ever inject anything. If there is bile, they stop immediately.
Okay, so if PAIR isn't an option or the cyst is just too complex, we go to surgical warfare.
Classical management.
This is open surgery, cystectomy.
Yes.
The source describes the safety measures here, and it really paints a picture. It talks about packing.
This is probably the most critical step in the operating room.
Right.
Before the surgeon even touches the cyst itself, they pack the entire surrounding area with abdominal pads.
But not dry pads.
No, absolutely not.
Yeah.
Soaked in scalicidal agents.
Soaked in hypertonic saline or hydrogen peroxide. I love the analogy we came up with during prep for this. It's like laying down blast mats around a bomb.
That's exactly what it is. You have to assume the bomb might go off.
You assume it might leak.
Right, so you create a kill zone around it.
So if any fluid drips out,
it lands on a pad, soaked in parasite-killing solution, neutralizing it before it can touch any of the patient's actual tissues.
It just emphasizes how terrifying that fluid really is. The surgeon is treating it like radioactive waste.
Surgery without these controls is, as the source bluntly puts it, dangerous.
You are better off doing nothing than doing surgery without spillage control.
Completely.
Now, despite all these precautions, things do go wrong.
They do.
The source material has an entire section on nightmare scenarios, also known as complications.
These are the things that literally keep surgeons up at night.
The most common one is rupture into the biliary tree.
Right. The cyst pressure grows, it slowly erodes the wall, and it just bursts into the bile ducts.
How does the patient know this has happened?
Pain, severe biliary colic.
And
then they turn yellow. Obstructive jaundice.
Because the ducts are blocked.
Right. The daughter cysts and the torn membranes physically clog the bile ducts, like debris clogging a pipe.
Then there is rupture into the peritoneum.
We touched on this one.
Right.
This is the cyst bursting into the free abdominal cavity. Anaphylactic shock. Immediate life threat.
But the one that really got me, the most visceral image in the entire document,
Oh, I know which one you're going to say.
is rupture into the bronchus, the lung connection.
This is truly rare, but it is unforgettable.
Tell us how that even happens.
Well, the liver sits right under the diaphragm, and the lungs sit right above it.
Okay.
Sometimes a cyst right on the top of the liver can erode upward.
Right through the diaphragm.
Right through the diaphragm and straight into the lung.
And the septum.
The patient starts coughing, and they cough up the contents of the cyst.
The source describes it as coughing up salty water and grape skin-like membranes.
Imagine that. Coughing up salty fluid and literal bits of parasitic membrane that look exactly like grape skins.
That is just horrifying, but also remarkably specific.
It is pathognomonic. Meaning, if a patient describes that, you don't even need a test. You know exactly what they have.
It really shows the destructive power of this organism.
It can literally eat through the liver, through the diaphragm, and into the lungs.
Unbelievable. Let's try to pull all of this together.
Okay.
The source provides a rapid recall algorithm. If we want to store this in our brains efficiently, how do we connect all these dots?
Think of it like a simple equation.
R.
Dog exposure plus peg layers plus clear fluid plus daughter cysts plus risk of spillage
Equals Hydatid cyst.
Exactly.
And the anchor concept, the one thing you really emphasize.
Management is designed entirely to prevent spillage.
Whether it's giving albendazole to weaken it,
or using pear to carefully drain it,
or packing the surgery site with those saline-soaked pads.
every single step is about containment.
It's containment of a biological hazard.
It really is.
So we've reached the end of the guide.
We have.
The source suggests a final takeaway for you listening. If the examiner asks just one question, what is the most important surgical principle in hydatid cyst?
The answer is avoid spillage to prevent anaphylaxis and dissemination.
Simple, yet it carries the weight of life and death.
It completely anchors the entire topic. If you understand that, you understand the disease.
You know, as we wrap this deep dive up, I'm just left thinking about the fragility of it all.
How so?
Well, we walk around thinking our bodies are these completely impenetrable fortresses.
Right.
But here's this microscopic egg, a total accident from a dog that just gets into us.
Yeah.
And our body, in its attempt to actually protect us, with the liver acting as that first filter, it actually creates the perfect environment for this invader to build a fortress of its own.
It is a massive paradox.
Yeah.
The liver does its job perfectly, so well that it catches a killer, but by catching it, it creates a medical emergency.
It walls it off to save you, but that wall makes it so much harder to remove.
It's a battle of biology, fought on a cellular level with the highest stakes imaginable.
And thankfully, we have surgeons who actually memorize these high-yield guides to defuse the bomb when it happens.
Indeed we do.
Well, that's it for this deep dive. Stay curious, wash your hands after petting the dog, and we'll catch you on the next one.